Hello, CTSNet community. I'm Mara Antonoff, and I'm a thoracic surgeon at MD Anderson Cancer Center in Houston. And I'm thrilled to be interviewing our 7th winner of the CTSNet Resident Video Contest. I'm joined today by Julia Coughlin. Julia is a general surgery chief resident at Rush University in Chicago. She'll be graduating this year and going to the Brigham for her thoracic surgery training. Julia, welcome. It's great to have you here today.
Thanks so much for having me.
I'm hoping you can tell us, what is the title of your outstanding video which won our contest?
The title is Successful Use of an Endobronchial Valve for Postoperative Bronchocutaneous Fistula in Pneumothorax Necessitans.
Well, that's very interesting, just based on the title alone. Of course, we probably all have some familiarity with the use of valves for a variety of reasons in postoperative care for thoracic surgical patients, but pneumothorax necessitans is certainly not something that we see very often. I'm wondering if you can tell us a little bit about the background of the patient in this case.
Sure. Our patient was a 67-year-old male who was diagnosed with stage 3A squamous cell carcinoma of the left upper lobe. He had undergone neoadjuvant chemoradiation and underwent a left thoracotomy and left upper lobectomy. However, his course was complicated by necrotizing pneumonia and a chronic empyema, for which he required prolonged drainage with an indwelling chest tube, eventually a decortication, and a few months later, a coverage of the left apical cavity with his pectoralis muscle flap. But soon after his chest tube was removed, he developed a bronchocutaneous fistula and subsequent pneumothorax necessitans, which we ultimately treated with an endobronchial valve.
Got it. So how long after the initial operation for his cancer resection did this endobronchial procedure take place? Do you have an idea, just general ballpark?
Yeah, he underwent his initial operation in October, underwent his decortication about a month later, and then had his muscle flap about 6 months after that. And it was 2 weeks after he underwent his muscle flap for obliteration in the cavity that he developed the pneumothorax necessitans.
So quite a prolonged management for this patient.
Yeah.
Got it. So I noticed on your video that the patient had a particularly profound finding on a CT. It's really remarkable. I'm wondering, for those who had a chance to see the patient in person, was the diagnosis obvious on exam, or was the CT scan necessary to confirm?
A little bit of both. I mean, obviously from the scan, you can see that subcutaneous air collection is pretty impressive and definitely detected on exam. But I think the scan was worth obtaining to see what else his underlying pathology was.
Sure, absolutely. Well, it's really an impressive image. So once you had that finding and the diagnosis was quite clear and the diagnosis was sealed, what was the treatment that was undertaken at that time?
So he was brought to the operating room for bronchoscopic exam, obviously. We were able to use a 4mm Fogarty catheter to isolate the air leak to the superior segment of his left lower lobe, after which we were able to deploy a 6mm endobronchial valve into the superior segment airway, after which we clamped the pigtail catheter and saw that there was no reaccumulation of the subcutaneous air collection.
Okay. All right. And then after that procedure, patient's problem totally went away? Did he require further operative interventions?
No, we ended up keeping the valve in for about 6 weeks. His chest tube was removed the day after the endoscopic procedure. And after 6 weeks, we removed the endobronchial valve, and he had no reaccumulation or new symptoms after that.
Was there any fear that perhaps when the valve came out, you may be returning to the operating room, maybe for superior segmentectomy?
Yeah, I think there was definitely that fear, considering his significant surgical history at that point. But I think we're all very hopeful that the endobronchial valve would fix this problem for him.
Yeah, it sounds like an outstanding win and an innovative way to treat this that really worked out incredibly well. And I think some of the aspects that I really love about your video are not only that you used a novel, innovative approach to dealing with a problem that we don't see that often, but that it was particularly successful, and that your video really well illustrates all of the components of the workup and the treatment, so that others who may find themselves in this uncommon circumstance could follow the example that you've left for them on how to do it. I do want to ask, in terms of the endobronchial procedure with the valve placement, which members of the multidisciplinary team were involved, and is that the norm at your institution in terms of the team members that are part of this process?
Yeah, so this case was before we had designated interventional pulmonology. So it was actually just mostly the thoracic team. Since then, we have incorporated interventional pulmonology, so they take on a lot of these cases. But for this specific case, it was just the thoracic surgery team.
And for this particular circumstance, you mentioned that the valve was left in place for 6 weeks. Was that timing selected based on any specific criteria, or was it kind of just arbitrarily selected and it happened to work out?
Yeah, that's the greatest length of time these valves can be in place. So we elected to max out the time that we can leave the valve in place for him.
Got it. Well, I obviously saw a lot of benefits to this video. I thought it was outstanding. I'm wondering if you can tell us from your perspective what the reasons were for developing this video for the CTSNet community.
It's definitely a unique case. And like you said before, I think it's good to share cases like this where you're looking for alternatives to conventional methods, especially in challenging cases. For this patient that we had, I don't know if he would have been able to tolerate a third operation. So I think it's good to just share cases like this as learning opportunities for trainees and for thoracic surgeons who are already out in practice. It's definitely something that you can gain experience from.
Yeah, definitely. So for you as a chief resident in general surgery, what was your specific role in creating this video? How did you participate in it, and what were your responsibilities?
My responsibilities were obtaining the imaging and then editing the video. So I just used something simple like iMovie. I've edited some surgical videos before, and it's always a great learning opportunity to go through the imaging and the videos and take out what parts you think are the most important parts of the procedure so that you can just condense it down into an educational and surgical video.
Absolutely. It seems as though you certainly did a great job of narrowing it to the most important components. When you think about the audience for CTSNet, obviously, you may be maybe tailoring this video to surgeons in practice who may encounter this type of unusual patient complication, as well as individuals who may be studying for their boards or trainees who've never seen this before and are just going to be exposed. Obviously, there may be different take-home points for folks at different levels of their career. Specifically for trainees, perhaps general surgery residents completing their training or early CT surgical residents and fellows, what would you specifically advise that they could learn from this video?
Just that there's always different ways to address a problem, and it's good to have a lot of different options in your back pocket. This just adds to the armamentarium of a thoracic surgeon. And as a trainee, I think it's just good to know all the different endoscopic, minimally invasive, and surgical interventions that you could use when treating patients with really complex pathology.
Yeah, that's terrific. I would say another one of the aspects that I really enjoy about your video is that I feel it's been my observation that a lot of the videos that we are producing in our subspecialty in the current era tend to be videos of robotic procedures, because videos always seem to be obtained of those procedures. And there are a lot of other operations that we as a specialty do, and a lot of other procedures that we do. And so I'm always grateful for videos that show us endoscopic views inside the airway, inside the esophagus, videos of what's going on outside the body, open procedures. I think it's particularly valuable. I'm wondering, from your perspective as a trainee, do you think that's also important that we continue to have videos that show all these different views? And if so, how can we try to ensure that we keep producing high quality videos that don't just show us the same robotic procedure over and over?
Yeah, I think it's definitely important. And especially as a trainee, we have to hone in on our endoscopic technique just as much as our surgical technique, whether that's open or robotic. So it's good to see videos like this. It's good that this video garnered so much attention that now other trainees can see it and see that these are options for treating complex pathology like this. And I think we should just encourage trainees to keep getting cases like this out there so that everyone else can learn from something like this.
I think that's an outstanding point. Having been through this process yourself, what advice would you give to a trainee who wants to put together a video for sharing with the surgical community? Do you have any tips that you would offer them, or advice even how to begin, how to get started, and some pointers to get through the process?
Yeah, I would encourage any trainee to try and edit surgical videos as much as you can, even if it's a straightforward case. Going through the steps of the operation and being able to pick those out in the video just help you learn the case even better than just scrubbing it. So I think, whether it's a unique case or a straightforward case, record the video, edit it, and then you could always have that in your back pocket as an educational tool.
And how would you suggest that the trainee engage in the discussion with the attending about making these videos or editing them or submitting them for contests?
Yeah, I think attendings for the most part would be, very open to that. It's great to have a library of cases like this. Everyone likes hearing about the very interesting cases at these conferences because we all can learn from the experience. So I think just approach your attendings and ask, hey, is this a case that I can record and edit for you? And then we can kind of go over the key steps of the procedure and management together.
Yeah, I think that's great. Great advice. And certainly for cases like the one that you've highlighted in your video, you probably knew from the beginning this is an unusual case and it's something that you're going to capture. One piece that I think is also important to remember is we don't always know when something exciting is going to happen in the operating room. And I think it's our tendency to record cases where we know there's aberrant anatomy or it's an infrequent situation or a bizarre complication or a congenital anomaly, things of that sort. I think we oftentimes encounter very interesting findings or unusual events that we aren't prepared for. And sometimes those are the videos that are even more worthwhile. And those tend to be the ones that really are only captured if it's robotic or, it's a VAT surgeon who happens to record all of their VATS cases. I had to correct myself. I don't know if you noticed the verb that I first used was tape. That shows my age, that when I talk about recording a video, my immediate verb that I want to use is tape, even though there's no tape anymore. It's all clearly digital. But I think the point is the same nonetheless. We have a tendency not to plan to record what appears to be a straightforward case. And sometimes events happen that can still make them incredibly worthwhile. Do you think we should be recording every case so that we can capture those uncommon events?
Yeah, we actually have some of our general surgery attendings encourage us to record every single case and keep it on an external hard drive because you never know when you're going to come across some interesting pathology. And like I said before, even a straightforward case is worth editing because you just get more familiar with the steps in the anatomy of the operation.
Well, that's terrific. Clearly, our toolkit for studying and learning these cases is continuing to evolve, and I think it's just moving in a positive direction so that our trainees can really have a breadth of tools and materials available for continuing to further their education. Again, I think that the video that you made is really an outstanding contribution to the CTSNet library. I'm so glad that you submitted it, and I think a lot of people are going to learn from it. I guess my final question for you is this. What is your take-home point or lessons learned from this video that you'd advise for anyone who watches it?
Yeah, I think the main takeaway from the video is with complex cases like this, it takes some perseverance from the surgical team to accomplish a successful goal for these patients. Just because the patient has had some setbacks in their clinical course, I think it takes some creativity on the surgeon's part to figure out how to address the pathology at hand, and definitely exploring endoscopic and open or VATS or robotic technique for these patients is worth looking into.
Well, that's an excellent point. Again, thank you so much, Dr. Coughlin, for this outstanding contribution. Congratulations on winning the Resident Video Contest Award. I hope that you are very proud of yourself. You did an outstanding job, and I really appreciate you taking the time to chat with me today.
Yeah, thank you so much. It's been an honor.